Welcome to this new webinar of the ESG. My name is Nathalie Chabert-Buffet. I'm very happy to welcome you in this webinar. I work in Sorbonne University in Paris, France, and I am Vice President of the ESG. So this webinar today is, as all the webinars of the ESG, express the views expressed in presentations made at the ESG webinars are those of the speakers and not necessarily of the ESG. The presentation of any information regarding any specific opinion, commercial product or practice does not constitute an endorsement of the speakers or third parties' views, products or services. You will be able to ask questions using the Q&A button, and I will address the questions at the end of the webinar. And today we have two exceptional speakers, Professor Andrea Genazzani and Professor Martin Birkhaeuser. So Professor Andrea Genazzani will talk about both of them will talk about the new challenges in menopause. You will see very challenging talks. The first one on androgen supplementation in menopause by Professor Genazzani. So he is a very distinguished, as you may know, academic leader in OBGYN. He was a full professor at the University of Cagliari, Modena, and Pisa for over 3 decades, and he received multiple honoris causa degrees from leading European universities and was a professor emeritus of the Ministry of Health and Social Development in the Federation of Russia. He is the immediate past president and executive director of the ESGE, the president of the European Society of Gynecology, and the International Academy of Human Reproduction. He also is the founder and former editor-in-chief of the Gynecological Endocrinology and currently editor-in-chief of GREM. Professor Martin Birkhaeuser will give a lecture on the practical implications of the drop of the black box in the United States. You know that this black box that was on drug boxes has been changed very recently, reducing the limitations of prescription of hormone replacement therapy. So Professor Birkhaeuser is a professor emeritus at the University of Bern, and he was the head of the division of gynecological endocrinology and reproductive medicine in this university until 2008. He has been an expert in menopause, osteoporosis, hormonal contraception, and he also received a Sharing Award for the research in polycystic ovary syndrome. He has held numerous leadership roles in international and national scientific societies, including treasurer of IAHR and ISGE, and he's the past president of several Swiss professional societies. He is honorary founding president of the EMAS and holds multiple honorary memberships in menopause and reproductive health society worldwide. So with these two very distinguished speakers, I think we're going to learn a lot. So Professor Andrea Genazzani, if you would like to share your slides, we can start with your lecture on androgen supplementation in menopause. Thank you very much.
Thank you very much, Nathalie, of that presentation. I will share my slides. 1 second, and then, okay, and then I will go on presentation. Oh, dear friends, I will speak today of androgen supplementation in menopause. These are my disclosure, but nothing concerning that presentation. I would like to start with the view of what is the androgen milieu and the estrogen milieu, both for men and women, and what are the differences. You can see here in blue the men with testosterone in the full line and dotted line estradiol, and in red the women. As you see, we have both of us an increase of testosterone and estradiol both in male and female at the second, third months of postnatal life. Then we go down for infancy until the moment when puberty starts. With that way, we have a profound rise of estradiol and testosterone estradiol in women and testosterone in men, and you can see that they remain more or less at the highest concentration, with challenging oscillation in women according to their cycle until the moment of menopause. While testosterone remain also more or less, it decline slightly, but it remain at high concentration. Estradiol in men also increases, and you can see here that also estradiol remain more or less stable around during all the life. The same for testosterone. After menopause, we have we have a slight decline of testosterone, but it don't look as so impressive, While there are also other androgens fundamentally in women, who are the adrenal androgens, and DHEA is the responsible. It has profound effect, and it's responsible. Its biological action is strongly perceived during pubertal maturation, and is called adrenarche. And adrenarche is associated to changes in sexual hair, in libido, in bone density, in stature, in muscle mass, and positive increase of immune function. All this is exactly the opposite during the menopausal senescence. Then, when we speak about the androgen, DHEA seems to have also very important effect. DHEA, which is in equilibrium with the sulfate molecule, DHEA sulfate. And if you see here, this is the trend of DHEA and DHEA sulfate. You see, we have a gender difference. Men have more or less 30% more than women, but in both gender, we have the highest concentration around our 18, 20, 22 years, and then it slightly decline progressively. DHEA is regulated by the ACTH, which is controlling the adrenal steroidogenesis. And the major responsible of the adrenal steroidogenesis and the ACTH secretion is cortisol, by the fact that cortisol can act on CRF production. But for cortisol, we don't have these changes. Cortisol have no gender difference, and circulating cortisol concentration are progressively increasing during all the life, while DHEA is progressively declining. Still, this one has not yet been established what is the cause. But in the meantime, this is the behavior of free androgen, free delta-4, free testosterone. You can see that also free testosterone have the highest concentration around 20, 22 years, and then it decline also progressively in a more important way, in fact, during fertile life, and also later on, even after the menopause. And if we put together delta 4 and delta 5 changes in women, and we look from the highest concentration around the 20s, how they go, you can see that at 40s means strong 10 years before the menopause, the women, they already had a 50% reduction of total androgen, who continues decreasing, and at 70, we reach the 77% reduction. This is strongly impressive and important, because in a biological way, you understand that a diminution of 50% represents a real important diminution. In fact, when we go now to the menopause and we see what are the symptoms of the menopause that we have already explained, that I've already discussed many times, we have central nervous system symptoms, symptoms from skin, mucosal, and hair changes, symptoms in weight and metabolic, in musculoskeletal, in urogenital, and in sexual function. And all these symptoms have clearly been established for the causes. But we have to think that when the menopause happens, there are not only the central changes showing the gonadal changes and the changes in the regulation of hypothalamus pituitary gonadal axis for the depletion of possibility to produce gonadal steroids. We have at the same time also the changes occurring in the adrenal gland, then the adrenopause, and the somatopause, the reduction of growth hormone and all the induced factors such EGF-1. And in fact, if you go to and if you see what are the causes of these symptoms, so for example, for vasomotor symptom and sleep disruption is the increase in central noradrenaline, the reduction in dopamine and serotonin, but also the important increase in neurokinin, kisspeptin, dynorphin, and cortisol. And if you go in all the other symptoms, you can see that as far as mood and cognitive function, but also urogenital, metabolic, muscular changes, bone remodeling, and skin aging, everywhere androgen reduction is one of the important factors who are co-responsible of these symptoms. This is very important. And you have to think, in fact, if you put what happened in DHEA, DHA sulfate, and aging, and if you add also the menopause, the lack of androstenedione and testosterone from the gonads, and the lack of DHEA and DHA sulfate, certainly they have an effect on central regulation of libido, mood changes, cognitive function, and well-being. And even more, if you think that you have that increase in cortisol going on with the age, who stimulate gluconeogenesis, but they have also very important neurotoxic effect and stimulate neuronal ability. If you put that one together with what happened in aging and menopause, who have with the reduction of estrogen, but also the reduction of DHA, androgens, and allopregnanolone, certainly that anxiety, depression, cognitive function, mood, and libido can be associated to important changes during that one, because all these factors are responsible also for the activation or the control of all these symptoms. And I would like to tell you something more concerning the effect of hormone therapy. We have published many years ago that the administration of any androgen, starting from transdermal estradiol only, or associated oral or transdermal associated with any kind of progesterone, is associated with an increase in allopregnanolone. That means an increase in the function of alpha reductase activity. But in the other side, all of them, with the exception of tibolone, because tibolone is a progesterone, but all the estrogen-associated treatment are associated to a further reduction of DHEA. This is something that we have to maintain in mind, because DHEA after the menopause, still always in equilibrium with the sulfate, is responsible by its peripheral transformation by the beta-hydroxydehydrogenase to androstenedione, who can be aromatized to estrone, and then later on androstenedione, 17-beta-hydroxysteroid oxidoreductase, can transform to testosterone, and testosterone can be either reduced to dihydrotestosterone or aromatized to estradiol. Then after the menopause, we have no more follicular or luteal production of steroids, all circulating androgen and estrogen originate from DHEA metabolism. And inside to the cell, the concentration in peripheral tissue are absolutely higher than those present in peripheral circulation. In peripheral circulation, only 3-alpha-diol 3 or 17 glucuronate is representing what is the full pool of gonadal steroid. But the peripheral circulation of either testosterone, estradiol, or DHT are absolutely incomparably lower than what are in peripheral tissue. And it's important to remember that after the menopause, all androgen and estrogen originate from DHEA. And what happens if you give DHEA to postmenopausal women? I would like to focus your attention that we have produced these slides more than 25 years ago. In azure, you can see here the normal concentration for fertile life. And you can see what happens if you administer 10 milligrams in green, 25 in red, or 50 milligrams per day to postmenopausal women, what happens in circulating concentration of DHEA, DHA sulfate, androstenedione, testosterone, and DHT. You can see that the continuous administration, this was for 50 milligram only for 6 months because we achieve too higher concentration. But for the other, for 25 and 10 for 1 year, we have a time-dependent and dose-dependent progressive rise of all these delta-4 androgens and delta-5 androgens. And associated to that one, we have also other very interesting effects. A time-related and dose-related increase of estradiol, but also changes who are not coming from the metabolization of DHEA and DHEA sulfate. You can see here we have a slight and progressive increase also of progesterone. We have a progressive increase of beta endorphin from propionmelanocortin, while cortisol is progressively reducing the concentration. But also allopregnanolone is progressively increasing. This indicates that the DHEA administration can also touch other steroids not originating from the DHEA, but that means that the DHEA can interfere with steroidogenesis either inside to the adrenal gland as well in the other organs. And when you challenge, when you examine the basal concentration of 17-hydroxyprogesterone and cortisol, which is the derivative from 17-hydroxyprogesterone, you can see that in basal condition, either in younger postmenopausal 50-55 in white, as well in 60-65 in green, you can see that you have a progressive increase of 17-hydroxyprogesterone cortisol ratio in baseline. And if you stimulate with an ACTH, with the same dose of ACTH, this individual, you can see that the ratio of the 17-hydroxyprogesterone and cortisol values under ACTH test remain the same according, remain the same in both groups of age, increasing after 3 months, 6 months, and 12 months of therapy. What means? This means that the DHEA affect the activity of the 21-hydroxylase and the 11-beta-hydroxylase, the enzyme responsible for cortisol synthesis from its precursor, 17-hydroxyprogesterone and 11-desoxycortisol. Then DHEA touch the metabolism of cortisol. And given a smaller dose with 10 milligrams, we have compared the effect of DHEA on sexuality total score, relationship total score, and sexual intercourse total score in comparison to a vitamin D as a placebo, or in green hormone replacement therapy, transdermal estradiol and progesterone intravaginal, or tibolone, which is well recognized to have an effect on women's sexuality. You can see here that also DHEA strongly increase the sexuality total score, don't change the relationship, certainly is very important, and increases also the sexual intercourse total score, showing that it have really an androgenic effect. And when given 10 milligram only, together with transdermal, with a patch of transdermal estradiol of 50 micrograms and 100 milligram intravaginal micronized progesterone, look please, and you give also DHEA alone in green or added to estradiol and progesterone in red, you can see how we have a continuous progressive increase of progesterone, also giving only DHEA, an increase in allopregnanolone, an increase in beta endorphin, an increase in estradiol, and certainly if you give together with the patch, it's even more, and an increase in estrone too. That's showing that really DHEA can provide a profound source of circulating steroids. And also the delta-4 androgen, DHEA alone, you can see here, on androstenedione, but also when given with estrogen, you have a progressive rise, and here on the same data on testosterone. By the way, it was interesting also to see what happened if you give testosterone. Okay, there are many, many data concerning testosterone. This is association between testosterone and cognitive performance in postmenopausal women. You can see here, we have a huge series of studies, but the findings for testosterone and cognitive function were inconsistent and inconclusive for this author at that time. In another study, endogenous testosterone concentration and muscular mass strength and performance in women, you can see this was, they included a lot of patients, and then at the end, they have no association between testosterone and muscle mass, strength, or performance. And another study done on safety and efficacy of testosterone for women, a systematic review evaluating in postmenopausal women with hypoactive sexual desire dysfunction. Testosterone improve frequency of satisfying sexual events, also desire, arousal, organ pleasure, sexual self-image, and reduces sexual distress. In premenopausal women, they have insufficient data. It was published by Islam in 2019. And in another general study, we have no sufficient data to draw conclusion related to cognitive function, muscle mass and performance, bone health, and other condition of disease still by Islam. And when the author have examined the side effect, because you have seen that testosterone concentration don't vary such a DHEA sulfate so widely during the women life. Testosterone, they vary, but the concentration the variation is limited. This means that the women can be very sensitive also to the administration. And in a series of studies, we have seen that we have some data about side effects, either about acne, alopecia, clitoromegaly, increased hair growth, and also in voice changes. Then, remaining, at the end, we have to remind that the DHEA remain the only source. It's important to take notes that DHEA can be transformed until estradiol in adipose tissue, skin, bone, cardiovascular, brain, and the vagina, but not in mammary gland and not in endometrial tissue, because either the mammary gland as well as the endometrial tissue, they are not the enzyme responsible for DHA transformation till estradiol. And in effect, 1 year of treatment bring atrophic atrophy with DHEA, bring atrophic endometrium, and because for this lack of transformation. Another question: what are the role of androgen in the changes of external genitalia and vagina that women who have the genitourinary syndrome of the menopause? As you know, in the genitourinary syndrome, we have a lot of structural changes during the menopause, but those estrogen dependent are only the epithelium thickness of the vagina, the diminished lubrication, and the increased vaginal pH. All the other are androgen dependent. Then this makes a very important difference. And it's important to remember that for sexual dysfunction, if we have a vulvar senescence, it's very important the local administration of testosterone, because ectodermic tissue, they have profound number of testosterone receptors and they positively respond to testosterone. But if the question of vulvovaginal atrophy, if it is only estrogen related, absolutely not. All the other hormones also can have an effect, and also mainly DHEA. And in addition, androgen are fundamental for the changes to happen during the aging of the women, also because they are responsible, partially responsible, also of the sarcopenia, in addition to the changes of the nutritional status of the skin, of the changes in metabolism of mitochondria, the important rising of oxidative capacity. Then we have to remind that this effect of androgens for sarcopenia is also fundamentally important. And the impact on the muscle by DHEA can be well recognized if you give DHEA per vagina. The beautiful study done by Fernand Labrie many years ago, no, a few years ago, he found that the administration at local level in vagina of DHEA increased the thickness and emulsification of the epithelium, which is the first layer, but also increased the density of collagen fibers and thickness of the lamina propria, and stimulate musculature layer and specifically nerve ending, and increases androgen receptor density in the 3 layers, increasing the vaginal weight, an effect 50% related to estrogen, but 50% due to androgen. Then all the organ increases. And this is important if you want to maintain also sexual activity, because also to face to coital activity, we need that the vagina can maintain its structure in all the layers that she is composed. And in addition, very recently, Tommaso Simoncini and this group, they have found that the vaginal DHA have an effect also on stress urinary incontinence, because also all the other tissues, such as the blood and the urethra, are sensitive to the androgen, to the local androgen administration. Then what are the tips and tricks for DHA? If peripheral DHA sulfate concentration reach 1 or 1.2 milligram per liter, we need to restore to 2 to 2.5, which are the values of a woman around 30, 25, 35. Starting with 25 milligram a day, checking DHA sulfate every 6 months, and modulating the concentration. And you have to remember that also DHA sulfate start to decrease long before the menopause, also in young women, and then in those who have complained regarding the changes, mostly in the sexual behavior, we have to evaluate DHA sulfate also in young women and take care of that, mostly if they're taking estroprogesterone contraception, because this blunt and decreases also DHA. Then, concerning to the benefits of menopause hormone therapy, dear friends, is the correction of all these symptoms, but mainly the effect on cardiovascular system, which are important. All these changes giving a proper administration of adequate amount of estradiol, natural progesterone, and also, I think, DHA. Then menopause, adrenopause, and somatopause can be considered a cause of frailty, vulnerability, sarcopenia, bone loss, diseases, loss of sexuality, and changes in lifestyle. And certainly estradiol, progesterone, DHA, and testosterone, topically administered, are the factor who can manage that one. Also because we have to believe that the women that now who are living strongly longer after the menopause, they have to try to maintain some characteristic for their sexual life, which in nature was planned to be more attractive, more interesting, and reduced also in frequency during the life. Certainly, we have different phenotypes of menopausal women, going from premature menopause, surgical menopause, menopause in healthy women, or in women already with overweight and metabolic syndrome and hypertension, and what are women in late postmenopause, either normal with normal healthy or with metabolic syndrome and hypertension. For each one of them, we have possible therapeutic options. Please, looks like that this therapeutic option can start even before the menopause in women who have a premature menopause or a surgical menopause, or women healthy with menopause. We start with the treatment. We correct after one more or less 10 years of treatment. We reevaluate the treatment and we correct the treatment. We can have an integration with androgen according to the female needs. In women already achieving menopause already with metabolic syndrome, we have to give only by transdermal route, not by oral route, not to touch, to stimulate the protein synthesis inside to the liver by the oral estrogen administration, only transdermal therapy. And also after 10 years, you can reevaluate. But also in these women, you have to take care of what they are the androgen, mostly at least until from the 50 to 60. This is very important. That, my dear friends, what are my conclusions? I'm sorry if I was probably too rapid, but my conclusion are that DHA sulfate is a major precursor for intracranial steroid production and reflects, at least in part, the capacity of the target tissue to produce delta-4 androgens and or estrogen. DHA supplementation in postmenopausal women is effective in restoring physiological levels of circulating delta-4 and delta-5 androgen and estrogen. And DHA supplementation increases steroids that are not directly correlated with metabolism of the androgens, such progesterone, 17-hydroxyprogesterone, and allopregnanolone, affecting directly adrenal enzymatic pathway. DHA supplementation affects directly central and peripheral level of endogenous endorphin, exerting an estrogen-like effect. You can imagine how this can counteract the aging process. And testosterone, we have still now limited study and lack of robust evidence and inconclusive data for the general therapy, but we have very important data for the local therapy against the genital senescence. Then, my dear friends, as we have to consider that the menopause and all these therapies are done not only to correct the symptom of the menopause at the menopause, but also to try to modify the process of aging and the process of aging, touching all the different organ and system. And we have to try to correct the evolution, which is normally from a single morbidity to a multimorbidity, who can bring adverse outcome at the end that I have mentioned. Then age is the most important risk factor for the age-related disease. Age-related multimorbidity impact on healthcare cost and quality of life. Common mechanism of aging underpins age-related diseases, and intervention targeting those mechanisms may delay the onset of multimorbidity. And what are the interventions? Certainly the lifestyle, but also the estradiol, progesterone, and DHEA supplementation to try to reduce the speediness of this evolution and to maintain the quality of life. Then, my dear friends, I thank you very much, and I have the pleasure to invite all of you next year, 17 to 20 March in 2027, in the beautiful Porto, where the European Society of Gynecology will have our 17th Congress. Thank you very much for your attention.
Thank you very much, Professor Genazzani. That was great, very clear, very interesting and fascinating. So we will move to the next talk about the drop of the black box by Professor Birkhaeuser. If you can share your screen, dear colleague. I don't, yeah.
It's reappearing.
Okay, can you hear me?
Yes.
Yes.
Thank you for the kind introduction. And
your video, you have, okay, now it's moved. Perfect.
You see it, okay?
Okay.
Good afternoon, everybody. I'm happy to be with you, dear friends and colleagues. My mission is to speak about the practical implications of the drop of the black box that happened last year. I have no conflict of interest to declare. Here you see the black box to the right.
I cannot see the screen, Professor. I can see you, but not your screen.
But what happened? I put it on.
Did you share your screen?
I did. I share again.
Oh, yeah, please.
I think now you should see it.
It's coming.
Here it is.
You have it?
Fine. Yes, we do. Thank you.
Good. I said already that I speak about the drop of the black box in the last November. I have no conflicts of interest. And here you see the black box to the right. In fact, this black box warning has been based on only one trial, one equine estrogen, natural for equines, but not for humans, only one progestin, and only one way of administration. And to end with it, it has been studied in the wrong population, elderly women, unhealthy women. This black box made a generation from this one study, the Women's Health Initiative, and concluded to an increased risk of DVT, an increased risk of myocardial infarction, an increased risk of stroke, and an increased risk of dementia for all possibilities of administration of HRT. That was a wrong conclusion. To understand what happened, you have to make a glimpse on history. Menopause became popular and HRT became popular in 1960. And you see here the title of the first book discussing this possibility. It has been called Feminine Forever, published by Robert Wilson. And he declared in the entire realm of medicine, there are few forms of therapy with a more consistent record of beneficence. This book came out in 1965, and until 1975, the use of estrogen only as substitution increased considerably. In the last years, before complications have been visible, there have been about 40 million prescriptions for estrogens alone in the United States. In 1975, the first papers appeared showing that the use of estrogen alone induced a high risk of endometrial carcinoma. In some studies, the relative risk went up to 9. The result was a rapid drop of the use of estrogen only until some new aspects became visible. That was the renaissance of HRT between 1980 and 2002, more or less. The new evidence has been that the addition of a progesterone to the estrogen protects against endometrial cancer. And the second new elements that have appeared has been that the addition of, in addition to the significant symptom relief, we have a prevention of several chronic diseases. Only in the year 1994, several important articles have been published. 2 showed that HRT protects against bone loss from Bruce Ettinger and Deborah Grady. 2 have shown that HRT protects against coronary heart disease in women. John Stevenson showed a reduction of about 50%, Psati a reduction of about 44%, and 1 article postulated there might be a protection against Alzheimer's disease. That was only in 1 year. And these data have been supported by several other articles having been published in the following years. In this time too, we discovered that there's a window of opportunity, and we learned that it is essential for low cardiovascular risk to start HRT early, between 50 and 59 years, and to use lapse time since menopause of less than 10 years. So up to 95, again, we had a high increase of the use of HRT, estrogen alone and estrogen plus progesterone combined. Again, the prescription per year went up to 30 million a year in the United States. Then came the bomb in 2002. That was the first paper published from the results of the Women's Health Initiative. And the conclusions started of this article with the 5 words, overall health risks exceeded benefits. If you look at data, that hasn't been even true for this third publication. But the 5 words went around the world and led to a panic and a collapse of the prescription of HRT. If you looked at the data, that hasn't been supported at all by the real data shown in this article. We have to consider only the adjusted values in yellow, and then we see that has been no change, significant change in cardiovascular heart disease, no change in stroke risk, no change in breast cancer risk. There have been a trend, but no significant changes. The only significant changes have been increased risk for VTE and a decreased risk for total fracture. So we cannot conclude from this data that the risks outweigh the benefits. There have been some unusual aspects of this first publication coming from the Women's Health Initiative. The paper has not been reviewed. Most co-authors have not seen the final text before publication. The press has been informed in advance. The specialists have been let in the dark. I got several phone calls at that time, and I had no idea about the publication because it has not been submitted to the experts. Then the original data is still not freely accessible as it should be for the NIH study. And the numbers of the participants are not the same in all publications. So but quite curious aspects of this paper. There have been several misconceptions of the authors of the WHI when they planned the study. The average age has been 33 years at recruitment. So the window of opportunity has willingly not been respected, and no difference has been made between women in their 50s and their 70s. The reason was that they wanted to avoid dropouts, and they excluded all symptomatic women having vasomotor symptoms. So in fact, for this population, there was no specific indication for hormone replacement. And then the authors disregarded some classical contraindications willingly. And the prevalence of untreated hypertension and obesity was extremely high, so it was not a healthy population. The percentage of women being hypertensive or obese has been about 25%. Only 13 years later came some corrections. You see here the data of Manson published in 2013. In the upper part, we have the CE-only trial, and we discovered that all these factors here had no change or a beneficial change, in part significant decrease in some diseases, and only these two, deep vein thrombosis and pulmonary embolus, increased with oral CE alone. That was not unexpected because it was an oral treatment that you have chosen for the study. And if you go to the lower part, you see the combined arm CE plus MPA. And there we had, in addition to deep vein thrombosis, pulmonary embolism, an increase in stroke and an increase in breast cancer risk. All the other factors, again, have been without the change, or there has been a decrease of the risk. And these changes do have been linked to the choice of the progestogen. The cumulative 13 years data calculated as absolute change per 10,000 women years have been published by Roberto Lobo. And you see that coronary heart diseases, myocardial infarction decreased by 11 cases, breast cancers -7, and then total mortality -12. So we cannot say that this study is characterized by a higher risk than a benefit. In 2016, finally came a late confession from the USA. The results are being used inappropriately in making decisions about treatment for women in their 40s and 50s. However, in the US, the FDA still maintained the black box postulating a class effect, a wrong class effect for HRT. Then we had several important new data in the last years, from 2024 to 25. The first has been the first Canadian experience. They looked at the side effects on MHT in women above the age of 65 years, therefore in a high-risk population. They have only some adverse effects, some more hip fractures, 2 breast cancers, both ductal carcinoma. Both women have been treated and continued HRT 10 years later, symptom-free. Then we had 1 thromboembolic event while on oral MHT, and 2 had a colorectal cancer, and 1 had a gallstone problem. But no adverse events like stroke, myocardial infarction, or uterine cancers have been noted. Then we had the Medicare study, a big study. About 10 million women have been analyzed, again in an elderly population, meaning it was a population at risk. In Eastern-only users compared with never users, we had a benefit. In Eastern monotherapy beyond the age of 6, it was associated with a significant risk reduction in mortality, 19% of decrease, and that was significant. We had a decrease in myocardial infarction, 11%. We had a decrease in breast cancer risk. And so again, in this study, it couldn't be said that the risks are higher than the benefits. It was exactly the opposite in the medical study. But this study showed 2 other important results. The type of estrogen is important. The mortality risk reduction of E2 was significantly greater than that of CEE. And the way of administration is important. The confirmation of many European studies disregarded mostly in the US. The Medicare study confirmed that transdermal estradiol has a greater reduction of all-cause mortality risk than oral ET. In September of the last year, a new analysis of the Women's Health Initiative data has been published by Jacques Rousseff, the father of the study. He looked at the change in relative risk for CVD. And if you go to the CE alone trial, for all age groups, even the women between 70 and 79, there have been a significant decrease in the cardiovascular risk. If you look at the combined arm, there has been a decrease for the 2 younger groups, 50-59 and 60-69, and no significant change in the group of 70-79. Again, no negative impact if you look at cardiovascular diseases. Then another important study was published by John Stevenson and his group. He looked at MACE events, major cardiovascular events, and compared the use of CE and MPA with the use of estradiol and progesterone. The difference between the two groups was highly significant. Women using E2 and progesterone had a significantly low risk to have a MACE event. And if we look at the different groups involved in the study, we see that the positive effect of progesterone has not been different between younger women and women between 60 and 79. The effect was even more marked in the women of 60 to 79. And the MACE subtype didn't influence either the result. Heart failure, overall, acute myocardial infarction and stroke had all much better results if you combine E2, natural E2, with progesterone than if you use CEE and MPA. That brings me back to the E3N study, the French cohort, where many years earlier it has been shown that progesterone is better for the breast cancer risk than synthetic progestins. If you use estradiol and progesterone or estradiol and dydrogesterone, you had in this study no increase of the breast cancer risk, but you had a significant increase in the progestin groups with different progestins included. This study has been confirmed already 13 years ago by the Cortina Diverge study. Again, natural progesterone has been better than estradiol and synthetic progestogens. And a late confirmation of these results from the French studies has been published by Citonen last year. And we see that again, dydrogesterone is much better than all other progestins analyzed in this study, so that we have from different sites and different countries and different groups always the same result. Progesterone and dydrogesterone should be preferred. Back to the black box. The New York Times announced in November that the FDA will remove the black box warnings from hormone treatments for menopause. Here are the statements in the press release. Secretary Kennedy said for more than 2 decades, bad science and bureaucratic inertia have resulted in women and physicians having an incomplete view of RGT. He said we are returning to evidence-based medicine and giving women control over their health again. And Commissioner Macquarie stated this is, in my opinion, one of the greatest mistakes in modern medicine, the demonization of hormone replacement therapy. So in fact, the FDA came back only in last November to what we have said for years in Europe after the publication of the Women's Health Initiative. Here you see the statement of EMAS. This decision corrects decades of misunderstanding and supports a more informed, personalized approach to menopausal hormone therapy, and the statement of ISGE, concluding 20 years to see the obvious. We have to remember that Klaus Christiansen said in 2005, it takes a few months to publish wrong data, and it takes 10 years to correct it. In fact, it took more than 20 years. So coming back to the wrong conclusions of the black box, we have now accepted that there is no class effect of estrogens, there is no class effect for progestogens, and there is no class effect for different dosages and the different forms of administration in HRT. That brings us to the evidence-based medicine and to the definition, what it is and what it isn't. I cite here David Sackett. He published these statements in 1996. Evidence-based medicine is about integrating individual clinical expertise and the best external evidence. Evidence-based medicine is not restricted to randomized trials and meta-analysis. That was the main mistake of the FDA. It involves tracking down the best external evidence with which to answer clinical questions. And the important last paragraph, if no randomized trial has been carried out for a patient's predicament, we must follow the trail to the next best external evidence and work from there. And that recalls us the Nurses' Health Study, an excellent and the first solid prospective open non-randomized observation study in normal health young women. It included over 120,000 nurses in the right age, around menopause, recruited at the age of 30 to 55 years. They have been recruited in 76 and followed up for 25 years, and the cohort follow-up was over 90%. And this study shows a reduction of cardiovascular and total mortality. And I think the conclusions of this study have been neglected in the United States for years in favor of the not so ideal Women's Health Initiative. Then we have to consider that in the climacteric, it can be argued that women who are willing to be randomized in long placebo-controlled trials are not representative of the normal patient population. And women RCTs are often motivated to do so because of free care. And that is the case particularly in the USA and in some former East European countries where free treatment is only available to the participation in the study. And then in MHT trials, absolute blinding is not possible. We have sometimes bleedings. We might have changes in the symptoms like hot flushes so that you can discover who has which treatment. Now I have to pass to estetrol to end my communication because estetrol has been approved 4 weeks ago by the EMA. The full indication of estetrol is, confirming to EMA, hormone replacement therapy for estrogen deficiency symptoms in hysterectomized postmenopausal women and HRT for estrogen deficiency symptoms in non-hysterectomized postmenopausal women with at least 12 months since last menses. That, in my eyes, is a very important introduction of a new possibility. You see here the clinical application recognized until now. We have the use in contraception approved for several years already, and we have the use in menopause approved 4 weeks ago. And then are still some other possible indications under investigation. One might be breast cancer, other might be prostate cancer, and one study is running in women having a COVID infection. But there we don't know yet what will be the outcome. The estetrol can be considered as something like a natural serum. We have effect on the brain. We have proves that there is a vasomotor symptoms relief. We have an effect on breast that might be favorable, more favorable than classical HRT. We have an effect on liver with a minimal impact on SHBG synthesis, showing that the liver is less influenced than by classical estrogens. We have a minimal impact on hemostasis parameters and a limited impact on lipid profile. All have a favorable effect if you look at the clinical data available today. Then we have an effect on the uterus with inhibition of the medium. We have a probably positive effect on fracture risk. It has been shown that there is a prevention of bone demineralization, and we have a probably protective effect if you look at the cardiovascular risk. We have, if you look at the basic data available today, a cardioprotective effect. At the EMAS Congress last year, this abstract has been published by the group of Tommaso Somincini and Michel Fouadard. It has been published in this first abstract by week 12. The 100% responder rates increased to 33% for E4 in the dose of 50 milligrams, and that 20 milligrams of E4 had a responder rate of 38%. The placebo group had a responder rate of 17%. The difference has been highly significant between placebo and the E4 groups. So I come to the conclusions. The results of the Women's Health Initiative trial are not representative for a symptomatic, non-obese and normotensive peri and early postmenopausal population, and for regimens other than the one oral regimen tested with CEE and MPA. If some US guidelines written mainly by non-endocrinologists still believe that this trial is representative for all forms of MHT at all ages, it is against the principles of evidence-based medicine. At least FDA has recognized these facts and has taken away the black box. Real-world evidence suggests that the MACE risk is significantly lower among women treated with E2 and progesterone compared to CE and MPA. These results are consistent with indirect evidence from prior studies suggesting that MHT with estradiol and micronized progesterone is superior to synthetic progestins. E2 and P4 are both chemically and biologically identical to endogenous hormones. We can state that there is no class effect for MHT, that MHT remains the most efficient treatment for climacteric symptoms. For treatment of symptoms, the lowest effective dose should be administered. The non-oral route should be preferred, and if needed, micronized progesterone or dydrogesterone should be preferred to all other progestins available on the market. MHT has additional beneficial metabolic effects that is recognized too today on bone, cardiovascular system, and there is probably a neuroprotection. What is valid in the elderly? Today we have no reason to place arbitrary limitations on the duration of MHT. The decision to continue depends on the individual risk profile. Again, the lowest effective dosage has to be chosen, and in elderly women, half an estradiol patch of 25 micrograms might be sufficient for the treatment of symptoms in some cases. After the age of 65, estrogens should be administered transdermally only, and other progestins and micronized progesterone and dydrogesterone should be avoided. Then we have a new tool in hormone therapy, estetrol. There has been shown that there is a therapeutic benefit in relieving postmenopausal symptoms. There is a limited impact on hemostasis parameters that may translate into a low risk of ET compared to other estrogens used in HRT. We have a beneficial effect on lipids and glucose metabolism, and that might translate into potentially lower cardiovascular risk profiles. And the same can be said on bone. The data available today might translate into a lower fracture risk. So these data suggest the potential of an improved oral estrogen-only HT. There are, of course, valid and evidence-based non-hormonal alternatives to HRT. However, if the indication of HRT is well established, we should consider the old British saying, it is unethical to endanger women by withholding MHT if MHT is clearly indicated. We are not living anymore in the 16th century, where women at 63 years looked like the mother of Dürer. We are at the time of Sierra Leone, where aging is quite different from aging in older centuries. Thank you for your attention.
Thank you very much for this talk. Very, very interesting, very full of hope for the care of postmenopausal women. Both of your talks gives us many new opportunities to offer to these women, going further beyond 60 with the treatment, androgens, estetrol. So this is a new era probably in MHT that is coming. So I have questions from the audience. The first one is on DHEA, which is a minimal effective dose, and when is the latest moment that we can start in postmenopausal women, 5, 7, 10 years after menopause without any previous HRT? And what about vaginal estradiol and DHEA? So Professor Genazzani, I think this is for you.
Thank you very much. Okay, the dose, the minimal effective dose, it can be established on the basis of circulating DHA sulfate concentration. We have to give a treatment. We cannot rise DHA sulfate above 2.53 microgram per milliliter. And but the moment of starting the treatment, it can be any one. we have no indication that we can start, because no study was done comparing the effect starting in a younger individual. We have made some studies showing that if you start at 50, 55 or at 60, 65, we have the same results. But in some women, we have also started in older age. There are no randomized control studies done to evaluate that one. And the vaginal DHEA can be also associated to vaginal estradiol. As you know, vaginal DHEA normally is given once a day for 1 month, and then later on we diminish the dose to every second day. According to the biological condition of the woman, you can also use, it's no contraindication to use also when you don't give DHEA the other time, also estradiol. This has to be evaluated with the patient.
Thank you. So the second question was the same one. I have one question for you. What do you do with women who had breast cancer in the past? What about DHEA? Can you give it to these women who had breast cancer?
Okay, this is a very, very interesting question. We have we cannot give us an indication because there have not been done any studies on that one. But you have to see the difference. The Food and Drug Administration have not put any black box also in breast cancer sufferers on the use of vaginal DHEA, while EMA, the European Medicine Agency, have put the black box because believe that as DHEA can be metabolized to estradiol, we have, for prudence, they have used the same indication as for estradiol. In our personal activity, in women who had already breast cancer, and we, according to them, if they have an vulvovaginal atrophy and we cannot use any other treatment, we discuss together the possibility to use DHEA.
Okay, thank you. So I have one question for Professor Martin Birkhaeuser. How many years should last the hormone replacement therapy?
How many years means how long, in fact.
I guess.
For limitation, if there is an indication that is absolutely clear, if the patient is suffering heavily from symptoms, we should stop HRT. That would be a mistake. I remember a patient of 84. The family doctor stopped HRT. She became miserable, had a low quality of life. We had to start again, and she could work again as an architect at that age. So I think if we make the balance between risk and benefits, we are allowed to continue.
Yeah. What is the big difference between bioidentical HRT and traditional, meaning the American one, I guess?
Well, for European, it is a difficult question because we don't have the same separation of the two principles. I would say what is important is that the product is really tested, that you know exactly what is in your tablet. And if you use bioidentical substances not approved by an excellent lab with all the tests done you need in vitro, you shouldn't use it.
Okay. You discussed the different progestins in HRT and the risk of breast cancer, and you did not discuss the endometrial cancer risk. So what is your opinion about that?
You're speaking now of estetrol or?
No, the traditional HRT.
If we take progesterone, for example, we are based on the experience that dosage between 200 and 400 should be sufficient, and it is generally accepted that if you use 200 in a cyclic way, at least 12 weeks per month, you're on the good side. And if you do a continuous estradiol administration, 100 micrograms should be sufficient orally. You cannot use transdermal progesterone, that's important to mention, because their resorption is too individual and depends from one skin to the next. You have no safety guaranteed. You have to use oral or eventually a vaginal progesterone, but the vaginal data are less stable too. So I would prefer oral progesterone.
Okay, so based on the E3N cohort study, I usually take dydrogesterone That's what I prescribe because there is no risk, at least during the 5 first years.
And there, I use usually, if I give it in a cycle, 20 milligrams for 12 days and continuously 10 milligrams.
Okay, thank you. One more question for Professor Genazzani. Is the HGA replacement alone efficient or always a combination with estradiol and progesterone?
Thank you very much. Okay, it's absolutely efficient also by alone, but we have to make a comparison. If the patient is coming for menopausal symptoms and she have a constellation of symptoms where hot flashes are the dominant one or a sleep disorder and so on, I don't consider the HCA alone. But if women are coming even sometime after the menopause with not so much symptom, but complaining the reduction of attraction to sexuality in general also is not too much the coital activity, but also the general believing, the general perception to be a sexually oriented individual, I evaluate the HCA sulfate and I treat them also only by the HCA. And also we have, I think that when we conceive what is human aging, menopause is an event to have specific symptoms, but aging is something we start since the beginning of our life, since the embryonic life, the aging process. But inside to the aging process, there exists that after the adrenarche, we have that continuous depletion of delta-5 androgen and other steroids coming from the adrenal gland while we have that cortisol increase. Then I think that we can conceive that the HCA in association for the menopause, some menopause area, can be considered as an anti-aging treatment.
Okay, thank you very much. I have one question on HRT again for you, Professor Birkhaeuser. For healthy women without symptoms, aiming at prevention, brain, muscles, bones, which HRT is suggested, including the doses? What doses?
Well, I prefer, of course, naturally estradiol transdermally. That is the choice I would make. And I would add, as you do, dydrogesterone or natural progesterone, micronized progesterone. And the dosage, if you look at bone, should be for estradiol 2 milligrams a day. If you go below this dosage, you have a decrease in the success rate. For cardiovascular risk, it's less clear. I would say 1 to 2 milligrams could be sufficient, but their data are missing. And for the muscles, I said I have to speculate. I do not know any study aimed at that problem. But
okay.
Subjectively, I would opt for 2 milligrams.
Very clear, very clear. Okay, let me check for more questions here. Yes. Do you make short stops, 3 to 5 days, for resting the receptors? This is science on its way. So do you need to rest the receptors?
I didn't do it until now, no.
Can we use the HGA to help with postmenopausal symptoms, I guess, PMS? Or what can be done to prevent second phase symptoms like tiredness? Oh no, this is premenstrual syndrome, maybe. Tiredness and low energy apart from COC.
Okay, concerning premenstrual syndrome, we have made a series of studies many years ago about trying to evaluate what kind of steroid can be responsible, or if some steroid should be responsible. And the measure factor that we published at the time, was also John Studd, we agreed, so we discussed longer with him that point, was the reduction of allopregnanolone. The allopregnanolone is reduced in symptom in women who suffer of premenstrual syndrome or premenstrual dysphoric disorder, not so much the androgen. But if when we have evaluated the effect of androgens and we have associated the androgen with sexuality, which is always a difficult point because sexuality depends from so many individual factors, the personal history, what happened, but also the partner, what is doing, and so on. One of the characteristics, it was always that the women who complained that they have a normal sexual life before, and they complain at any age, even though if they are younger, they have reduced concentration of delta-5 and sometimes also of delta-4 androgen. I don't want to associate, but there is. Then we use DHEA supplementation in women under contraceptives after the evaluation of DHEA sulfate. If you evaluate DHEA sulfate, a huge series of women who complain the loss of sexual interest under contraception, they have concentration of DHA sulfate lower than 1.5 or 1.2 or 1.1 microgram per milliliter, who means that they have an anticipated, or I don't know if it's causally related, reduction of delta 5 androgen in comparison to what is expected. Then I integrate, in those women, we are also using an integration of DHA.
Okay. One question about estetrol. Can it be used isolated, which is without progestins, I guess, in women with a uterus? What are the risks of hyperplasia, Martin?
Well, we have, if you look at the decision of EMA, it's possible. But we have to recognize the study, the two phase 3 studies that have been finished some months ago have not yet been completely evaluated. So we are waiting for new data from these two studies to confirm what the preliminary data and the preclinical data suggest. But I would say it is safe and you can use it based on what is available to date.
Okay, I will take, if you agree with that, 3 last questions. There is one on what is your opinion about the use of testosterone in gel?
I am using testosterone in gel as anti-aging of the external genitalia area. Then in women who suffer the disappearance of the clitoris, of the labia majora and minora, the restriction of the vaginal opening. In this one, we are using 1 milligram by gel, by distributed in all genital area. Normally, we give 3 times a week for some time, and then we diminish to 2 times a week. It's very important also for women who suffer from from painful syndrome associated to the atrophic evolution of the external genitalia. Sometimes it happens also in younger individuals.
If I may add, there is a preparation approved in Australia, a very good one. And I think we should aim in Europe to get it approved by EMA, which we have nothing today.
Yes, yes. No, in fact, I am using only a pharmacy produced medication, not because we don't have any.
Is the IUS Mirena does the IUS Mirena increase breast cancer risk? If
Yes.
used in the postmenopause, I guess, or anytime. I don't know. The question is not.
The recent published data indicate that also levonorgestrel is an androgenic progestogen that increases the breast cancer risk. It has a huge series of advantages also. We have to balance certainly one and the other, but it is not neutral. It is not neutral.
And do we want to prescribe DHEA to treat osteopenia in menopause? Okay, in osteopenic women with low DHA sulfate, we associate to the estrogenic treatment. With any other treatment, we can also associate. You know, it's not a specific treatment because we don't have study, but androgen receptor are widely expressed in the bone. Okay. Okay, so I think it's time to say very many thanks to you both. Thank you for, this is science on its way again. The postmenopausal period for women is getting a new rebirth, let's say, I guess, with all the opportunities you've been discussing. So thank you very much for this very nice webinar indeed. And I wish all the audience a very nice end of the day. And thank you for being with us today. And we hope to see you in Porto, as was mentioned before. Okay. So
thank you, Natalie.
Everybody.
Bye-bye to everybody. And thank you.
Bye.